Thank you, Sripriya. Thank you all the participants for joining. Thank you all the participants and specifically Dr. Manjari for bringing those beautiful pictures every morning. So it's kind of, we are all really looking forward to see what's happening next day. So yeah, and thank you so much for that wonderful interactions happening within the group. I think that's the first time we are having these kind of conversations, active conversations in the group. So thank you everyone for that and being a part of it. So today we are going to deal with symptoms one by one. So we'll start with gastrointestinal symptoms, and these come across gastrointestinal symptoms very commonly in a palliative care setting, be it cancer or non-cancer. Those are very common, and the management becomes slightly different because we know that the intention to treat is different. So today we have Dr. Vineetha as our faculty. Dr. Vineetha was working with some of the corporate hospital setting in the Department of Palliative Care. She has done her post-graduation in palliative care, and now she's again doing her post-graduation in community medicine from Amrita Institute of Medical Sciences. And she was with us for quite a long time now as a faculty. And as Sripriya mentioned, we are so happy to see her again and again for those sessions. And sessions are really appreciated by all the batches of doctors. Thank you, Vineetha, for coming again and being a part of our program.
Thank you, Sridevi, and thank you, Sripriya, for once again inviting me. And it is a pleasure, totally a pleasure. So I think we should be getting on with our topic for today. Yeah. So I will just share my slide. Yeah. Is it visible like when I'm changing the slide?
Yes.
Earlier there was some issue. Okay. Right. Yeah. So hi everybody. I'm Dr. Vineetha, and today I will be speaking to you on GI symptom management in palliative care. So I don't like this to be just a lecture. I know you all are doctors, you all are practicing doctors. So if not all, at least most of you, I guess, I'm not quite sure of the background that you all are coming from, and how many of you have had exposure in palliative care. But I'm sure these symptoms that we are looking into today, nausea, vomiting, constipation, they are so common. And all of you might have been managing nausea, vomiting, and constipation. So how different are we going to look at it in a palliative care angle is going to be something new that you can take back home today, right? So let us make this interactive. Let us make this a sharing of our knowledges to each other. Okay. So I also learn a lot during sessions, because usually that's how we do it. We put in whatever we know about it. So always be free to use the chat box, or if you would like to add in something, speak on it, you can just raise your hand and speak about it. Okay. So GI symptom management, what we are going to do is we are going to see what are the common GI problems in this class and the following class. And today, basically, we are going to be concentrating on nausea, vomiting, and constipation. Okay, so what are the causes for these, and how are you going to treat them, and what are the things that you have to keep in mind when it comes to managing nausea, vomiting, and constipation in palliative care? Yeah. So can you please tell me, I mean, what are the usual antiemetics that you prescribe for your patients? You can use the chat box. You can type it in there. What are the common antiemetics that you would like to give your patient? Domperidone. Yes, Dr. Vijayaraj says domperidone. Dr. Anish says ondansetron. Dr. George, yes, Dr. Jason, Dr. Nari, Dr. Shabnam, Dr. Mrinalini says Dexa. Dr. Manjiri says metoclopramide, yes, promethazine. Dr. Shalini also votes for both. Yes, we do have Dr. Shabnam also saying apripitant. Dr. Anish Raj saying again granisetron. Yes, we again have Dr. Jennifer voting for Perinom, ondansetron. Yes, so pretty much yes, we also have palanositron. Okay, one of you have commented on that as well. So we know that there are so many antiemetics. But now the question is, who do we choose to give each of them? I mean, is there a criteria that we give, okay, this situation, we give these antiemetics. In this situation, we do not give these antiemetics. So this is what this class is on about. Okay, so I would like to thank you for your inputs there. We are going to keep continuing this. So yes, granisetron, promethazine, yes, we have all those entries there. Now, I'm going to start off with this case. Okay, so this lady, she's an old, frail lady who is 54-year-old with gastric carcinoma, who is on chemotherapy and is admitted in the general ward for treatment of a UTI. Now, she is admitted with vomiting, abdominal colic, and fever. And she is tired and has been admitted for completion of IV antibiotic. She has small, frequent, incomplete bowel movements for 4 days and is started today on laxatives. She is accompanied by her younger daughter. So I want you to think about this case and identify what are the issues of this 54-year-old lady. I have put a clue to concentrate on the colors in red and blue, which will lead you to the direction that you have to think along. And also, the question is, how would you investigate? And how will that help you in managing? Yes, Dr. Jyoti is like, we have to go for X-ray abdomen standing in erect position, okay, probably to rule out intestinal obstruction. And then Dr. Jyoti also says blood counts. Yes, okay. We probably also have to look at the blood counts because fever is there. Dr. Shabnam says gastric carcinoma, so probably patient is in a gastric outlet obstruction. Or probably Dr. Shalin also says it could be a chemo-induced nausea and vomiting. Yes, Dr. Anish also says probably probiotics, sucralfate, ondansetron is going to help her over here. So yes, it could be also a pyelonephritis, Dr. Aisha says. And then again, checking electrolytes is important, Dr. Jennifer says. Also probably a ureteric calculus has to be looked into, Dr. Smita says. And Dr. Aisha also says USG abdomen. Okay, thank you so much. It's so exciting to see all of you put in all these comments. Dr. Manjari says issue could be multiple causes. That is chemo-induced infection, constipation, anxiety, pain, and stress. I just love this entire list over here. So we are going to come back exactly to this case after the entire session today, because we are going to see how differently are we going to think. Now, all of you have thought about this and all of you have kind of an idea what are her issues, how are you going to investigate, how are you going to manage, right? So we are going to come back right on to the same case. And I want you to just think back on how differently you have been able to prioritize your treatment for her. Okay, right. So coming back to today's topic, we're going to come back to this case in a short while. So coming back to today's topic is vomiting or emesis. If I say emesis, it's probably going to just be a group of things like nausea, retching, and vomiting, all that comes under emesis. The three phases of emesis. So emesis is nothing but a defensive mechanism of the body to just remove all those toxic and harmful substances from the body, okay, after it has been ingested. So and now coming on to nausea, retching, and vomiting. How is it different? How is nausea different from vomiting? It's very simple, right? In nausea, the contents are not thrown out, but vomiting, you have the gastric contents coming out. So that's what we are going to go in next. Nausea is just an unpleasant sensation that they have to vomit. They keep feeling they have to vomit. And vomiting is there is a forceful expulsion of those gastric contents. And there's a contraction of the abdominal and chest walls. Whereas retching is a spasmodic respiratory movement against a closed glottis. So actually the gastric contents are not getting expelled. Whereas regurgitation, the food is actually brought back into the mouth. But here there is no much contraction happening of the muscles. Okay, so these may be the different types, the different definitions that we know of nausea and vomiting. Now, what are the different types of vomiting? In terms of, see, when I say over here like types of vomiting, of course there are a lot of different things that we have to keep in mind here. In particular, I was just trying to put it along time frame. Okay, so what would you call a vomiting where, you know, somebody ingests something and in a short span of time they just start vomiting? What type of vomiting is that? I mean, what is there a term for it? Yes, chat box. It happens suddenly. Okay, Dr. Vijayaraj says it's projectile. Okay, in projectile, probably there's no nausea associated. It's typically in head injury. Okay, acute onset. Yes, I get answers like acute. Yes. And yes, I also have answers here like projectile and non-projectile. Dr. Shabnam says, Dr. Smita says, yeah, they are all sudden. And okay, it also happens generally when there is a raised intracranial pressure, but we typically say probably there is no nausea associated with it. And it is more acute. So here, acute is the term that we would say for some for a vomiting that happens suddenly, right? So what if it happens after a while? After a while, say the trigger has happened and it's after a while that actually the vomiting is happening. What is the term that you give for that kind of vomiting? Delayed. Dr. Mrinalini says it is delayed. Yes, thank you so much. Now, what if, you know, somebody, say, suppose it's a chemo therapy that this patient has had, and it was a horrible experience that the patient had, right? So, yes, Dr. Shabnam will say chemotherapy induced nausea and vomiting, CINV. Yes. And what I was saying is that, say, suppose, you know, it was a very bad experience that the patient had. The patient was given chemotherapy. On the other side, the patient was vomiting. And this happened on the first day of chemotherapy. So what happens on the second day of chemotherapy? Second time that the patient has to go. Yes, Dr. Jyoti says anticipatory vomiting. Even before the patient reaches the bed, or probably even the previous day, the patient starts feeling nausea. Yes, Dr. Aisha also agrees to it, anticipatory vomiting. Or maybe even before the drug is getting infused, the patient starts feeling nausea and probably even vomits. So that is anticipatory vomiting, isn't it? So, so let's say another situation where the patient is on antiemetics. Right? The patient is on antiemetics in the morning and in the evening. Okay, 12th hourly. Now, what if the patient vomits again about 4 to 5 times by evening? By say about 8 a.m. and 8 p.m. is when the dosage is given. And the patient has, by about 5 p.m. onwards, the patient is having severe vomiting again. Breakthrough vomiting. Thank you so much. Dr. Newstar has said breakthrough. Dr. Snigdha also agrees to that. It is breakthrough vomiting, right? So now another situation. Yes, Dr. Vijay also agrees to breakthrough vomiting. Now another situation. Patient is on antiemetics, taking it regularly. Despite that, patient is having vomiting. It is not responding to the drugs that you've given. Yes, Dr. Manjari says it is refractory vomiting. Absolutely. So that's what we are. Yes, Dr. Smith also agrees to that. Refractory vomiting. Thank you so much. So that is what we are going to be looking into next. Acute, where it occurs within few minutes or hours and is resolved in 24 hours. So most often acute vomiting is that which it happens and it gradually weans off within 24 hours. Now delayed is occurring usually after 24 hours and will be worse from 48 to 72 hours, and it can last up to a week after the chemo is given. And this is typically, mind you, this is typically for chemotherapy induced vomiting. Right? And say acute vomiting is usually seen more in platinum-based compound chemotherapies. You have cisplatin and things like that. So they have more emetic potential. They tend to actually precipitate acute vomiting. And then you also have delayed vomiting. Now, most of the other chemotherapies also have delayed vomiting. You may have say paclitaxel or gemcitabine, many other chemotherapies. All right, so they all have rather a delayed vomiting. Okay, and then now breakthrough vomiting, like very rightly said, occurring despite anti-emetic treatment. Refractory, where it is unmanageable with the current anti-emetic regime. And anticipatory, where the condition response is prior to the chemotherapy. So all well said. Thank you. And what we need to understand from this is that managing vomiting for each of this is different. Right? So we will be coming back to how we are going to manage each one of this. So before we have been talking so much about we are going to manage, we are going to find the cause of vomiting, what are the different types, and we are having an entire session on how to control vomiting. Now, why are we giving so much of importance to vomiting? Why are we having even one entire session class on, how to control vomiting? Yes. Why is it important to control vomiting? To avoid electrolyte imbalance, yes. Dr. Vijay says so. Dr. Newstar says that it is very distressful. Yes, Dr. Manjari also says it makes the patient miserable. It's important for treatment completion, Dr. Malali says. It's unpleasant and decreases the compliance and quality of life, Dr. Shalini says. Yes, a lot of you do agree to that. It interferes with the compliance to the current treatment. Yes. Yes, a lot of you say that it is a very unpleasant and uncomfortable symptom. Dr. Newstar also said probably it could also lead to esophageal rupture. Yes, it could also probably give rise to other complications. Yes, so, and Dr. Gregory also says about the acid-base imbalance. Probably that could lead on. And the feeling of sick or the low intake, that could be a sequelae to constant vomiting. And Dr. Vanti says. So thank you, that's great. So exactly, that is the reasons why we need to control vomiting, because it is going to affect the patient's daily functioning, the quality of life of the patient. And the patient is not able to eat properly. Always there is a nausea, which is so disturbing, so unpleasant, does not feel like eating. When the patient does not eat, the patient becomes more tired. It is going to affect his functioning, unable to conduct his normal routines for the day. has to depend on people. So all this is like a vicious circle. Now, again, non-compliance to cancer treatment. So remember the situation I was telling, the patient went in for his first chemotherapy, the first day, where he had severe acute vomiting right at the bedside. And even after coming home, it was quite distressful. Now, what is going to happen? This patient is going to keep persuading the family relatives that I do not want to take that treatment anymore. So this is what is going to happen. Or probably it is oral chemotherapies that the patient is taking. The patient might slowly just skip a few doses, thinking that maybe it is this dose that is creating the vomit. So all this is going to affect the compliance to the cancer treatment. And again, refusal of effective pain medication. So what if this patient is also having severe pain, which a cancer pain, which is being controlled with pain medications? Now, because of the vomiting, the patient is not able to take even the essential medicines that the patient has to take. And also the pain medications, which is controlling his pain. Now, what happens? Vomiting is going on, patient is becoming tired. At the same time, patient is in pain also because the pain medicines are not being. Okay, so this is just kind of diversing on and branching on to a big tree there, which is going to just affect the patient's quality of life. And when the patient is going through so much of distress, definitely the family is also going to be in great distress. Okay, so now coming on to what exactly are the causes for vomiting and nausea and vomiting. So what do you think are the causes for nausea and vomiting? Causes. Yes, chat box. What could be the reasons? Well, we did already say chemotherapy, radiotherapy. Yes, Dr. Shabnam says. Also local generalized infections, Dr. Manjari says. Yes, great. And Dr. Vijayaraj also says gastritis. Yes, also would like to add obstruction. And again, Dr. Mohammed also agrees to chemotherapy. Yes, drug-induced, Dr. Neelam says. Again, raised ICT, Dr. Shabnam says. Dr. Manjari also says antibiotic-induced gastric outlet obstruction, Dr. Snigna adds, and also other medications, Dr. Shalini adds. And the tumor itself, yes, Dr. Smita says even the tumor itself obstructing and causing it. Yeah. And then Manjari, doctor also says about the opioid-induced vomiting. Yes, Dr. Sujay also says about GERD, gastroesophageal reflux diseases. And Dr. Grigory also adds to electrolyte imbalances, which also probably could lead on to vomiting. That's excellent. Like we have hypercalcemia that could also present as vomiting. Then Dr. Manjari says post-op, dehydration, migraines, all this could also lead on to vomiting. And subacute intestinal obstruction, Dr. Charlene also adds on. And insomnia, yes, Dr. Mohammed says insomnia also probably can lead on to vomiting. Wow, that's wonderful. I really love that list there. Yes, so we are going to go on to the next slide. Yes, we have an entire reasons over here, chemically induced vomiting. So chemically induced vomiting, we did already get a list here saying it could be chemo induced, it could be other drugs, antibiotics, right? So let's open it up. Yes, it is opioid, antibiotics, cytotoxic like chemotherapies. And also you have other toxins like food poisoning, right? That could also lead on to ischemic bowel obstructions. Yes, ischemia, bowel ischemia can present as vomiting. And metabolic organic failure, where you have uremia. Uremia can also present as vomiting. Then you have gastric stasis, anticholinergic drugs, which can cause gastric stasis, and that can also probably worsen the vomiting. Opioids, ascites, where you have the abdominal pressure is getting increased. So that also can induce vomiting. And then you have gastritis, peptic ulcer gastritis. This can be caused by stress, or it can be caused by drugs like NSAIDs, it can be caused by radiation, or you can have even other situations like autonomic failure where there is a total stasis, right? Now, again, stretch or distortion, like in case of the GI tract, like constipation. Okay, constipation, the stretch itself of the mucosa causing nausea and vomiting, increase in the abdominal pressure causing vomiting. You have intestinal obstruction, you have mesenteric nets. All this can cause nausea, vomiting. Then again, liver metastasis, ureteric obstruction, all this can also cause. Again, like you had already mentioned, infection. Infections can lead to nausea and vomiting. And can you tell me one very commonly seen infection that can produce nausea and vomiting, especially in the elderly? Sometimes, when you go for home care and all that, you might just see elderlies telling that, yeah, I've been having severe vomiting. The family is telling that he or she has been having severe vomiting. And then you trace back and then you understand, okay, this is probably the cause. Yeah, thank you so much. A lot of you have unanimously said, yes, it is urinary tract infection. Urinary tract infection, often it can just present in a very bizarre way. Some of them just present, especially geriatric patients, they might just present with delirium and vomiting. So it needs you to like think back and probably have that checklist on what could be the different causes. And now what more are there? Yes, we also have the raised intracranial pressure reasons, or we have movement induced, like when you're going up a hill station or for a nice holiday, I mean, you end up vomiting. So vestibular issues are also a problem which can lead on to nausea, vomiting. And again, anxiety induced, anxiety or anticipatory vomiting, all this fall under that. And then environment. So why do we always blame the drugs and the other biochemical parameters or a gastric outlet obstruction or intestinal obstruction? Think also about, where is your patient? The patient is at home, okay? So what kind of food is being given to the patient? Sometimes families, out of so much of love, they think that, okay, being a patient, this patient should have very bland food, or probably, they get a maid to prepare the food. So the maid is preparing the food in a very special way, different oils used or something, which the patient is not able to actually feel interested in. And that itself, the smell of the food, the look of the food, everything may, or even the distaste for the food is very bland. That itself kind of makes the patient feel very nauseous. And then the smell. So, if you think of cancer patients, so they probably have a wound, they have an ulcer which is fungating, and there is a foul smell coming from that fungating wound. The smell of it, how would you like it if you were given a plate of biryani when there is a very foul smell around you? You would never feel like eating it, isn't it? Then about cleanliness. What if the patient is in a general ward where it is not actually quite clean? And that itself could make the patient nauseous. So it is equally important to also look at the environment of the patient, which is actually contributing to the symptom. Yes. So is that all? Have we completed the list, or do you think that there is still more? Do we have more to the list? Pain. Yes, Dr. Manjari says it could be any unaddressed other symptom or psychological symptoms that Dr. Jason says that it could be contributing to further nausea and vomiting. Anything more that anybody would like to add? Yes, a few other causes. We have oral thrush. When you have a patient going on telling you that they are not able to eat food for the past 4 to 5 days or a week, and what they eat is vomiting, ask them also to open their mouth, look for oral thrush. because it is so common in palliative care patients where, the immunity is compromised in most of them, and they are very vulnerable to develop oral thrush. And also probably good oral care is not being given regularly. That can lead on to halitosis. That also could precipitate nausea and vomiting. Dysphagia, dyspepsia, hiccups. Hiccups, probably the patient is having ascites, or probably the patient is having anything leading on to increase abdominal pressure, or probably the patient is having uremia. All this could lead to hiccups, and this could also be another cause for the nausea and vomiting. Mucositis. Your patients who are especially cancer patients on chemotherapy, on radiation, they are all prone to develop mucositis. Now, especially if it is of the oral cavity, the radiations of the oral cavity, they tend to develop mucositis. Patients who are on chemotherapy, they develop neutropenia, and that itself could lead to mucositis and worsening. So all these are different reasons and situations which could lead on to nausea and vomiting. Now, I want you to again think. If you look at it, the causes are different, so the way to manage each is different. You need to treat the cause before you just write an antiemetic. Or rather, you write both parallelly, is what I would like to add in. Okay, so without addressing the cause, it is improper to just prescribe an antiemetic. So while coming to choosing an antiemetic, identify the cause. That is what we were looking into. What are the different causes? And then we need to understand what is the pathway which triggers a vomiting reflex. And again, once you know the pathway, you should also be able to identify what are the neurotransmitter receptor that is involved in this pathway. Because this helps you to choose which antiemetic that you have to give. So you need to choose a potent antagonist to the receptor that is identified, and then you choose which route to give. Say the patient is having severe vomiting, you definitely have to give parenteral, because if you're going to give oral, it is not going to stay, and it is not going to produce the action. Now, also, there is no point just giving a single dose. You have to give it regularly, isn't it? If the patient is having severe vomiting, if you just give one IV and you're like, okay, that's done, it's not going to help. You have to give it spaced out. And the frequency should be based on which drug you're taking, and it has to be given regularly until the vomiting is controlled, and then switch over to the oral antiemetic. And once the patient is completely in control, you stop it. Right? So titrate the dose, monitor the patient, and administer regularly. Yes, so this is a diagram picture which shows which are the different pathways involved. So before we were talking about the anxiety which is causing which is causing vomiting, about probably the previous chemotherapy experience. Where is it going to go and trigger? It is going to, the pathway is through the cerebral cortex and further on to the vomiting center, which is producing the emesis. What about biochemical abnormalities? Uremia, you have hypercalcemia, all these things that is leading on to nausea and vomiting. And then you have drugs like chemotherapy. All these are going and triggering the CTZ, which further causes vomiting by stimulating the vomiting center. So as you can see here, this diagram clearly tells you where each of them originate and further goes on to the vomiting center and produces emesis. And then you also have receptors in the gut, which further through the vagal efferents stimulate the vomiting center and produces emesis. Another important thing that you have to also pay attention in this diagram, they have also marked the receptors with color zones. So you have the serotonin receptors, the dopamine receptors, cholinergic muscarinic receptors, histamine receptors, all these marked in color. So you know that if it is the cortex, you have the ibobutyric acid receptor there. If it is the CTZ zone, you have the serotonin receptor and you have the dopamine receptor there. If it is the vestibular system, you know that the cholinergic muscarinic receptor is there. So when you choose your drug, you need to choose your drug which will act on that receptor. So which are these drugs? So that is why we have this next table here. You have on the top row, we have all the different receptors there. And the receptor antagonist there. And these are the drugs which will help to antagonize these receptors. So this is how we choose the medications, right? So if we are going to have a patient with, say, what do you say? We are going to have a patient with a gut issue, like which is causing severe vomiting. We would like to block the dopamine receptors, right? So the dopamine receptors, that is the first column there, you can see the most acting, you have haloperidol, you have metoclopramide, you have domperidone. Yes, we have all that there. And we do not see much role for ondansetron, although like if a patient comes with vomiting and there is a practice of going for ondansetron, there's a, it is a, it is actually an intestine related issue. We might have to probably go for those which act on the gut. So there we will have to choose drugs like metoclopramide, or probably even something like haloperidol, which has a greater action. Okay, so here also, apart from this, we need to know that there are other areas like raised intracranial pressure, where the pressure receptors are getting triggered. And also intestinal obstruction and hepatomegaly, where there is a stretch of the capsule, liver capsule, which is causing the nausea and vomiting. And here is where drugs like dexamethasone plays a role. So that is not being given here, but that is where drugs like dexamethasone plays a role. So these slides will be given to you, so you could go through these two tables, two figures, this figure and this table on your own. Okay, so now coming to choosing the route of antiemetic. Like I said before, if the patient is severely vomiting, you will have to go for the parenteral route, IV or subcutaneous. You know, in palliative care, we usually go for subcutaneous routes because IV access is sometimes difficult for patients who are very tired. And sometimes we have to also go for continuous subcutaneous infusions, especially if it is terminal patients. You know, sometimes we have to, or it is very refractory vomiting issues, refractory vomiting situations. So we have to go for continuous subcutaneous infusions where the drugs are loaded onto a syringe driver and it is connected. And also once it is in control, we change to oral route. And sometimes we have to also go for suppositories. That is another option. And also sublingual. You do get these sublingual preparations of ondansetron, which is now commonly used. They are small little sublingual flavored, different flavors they have. And you can just put it on and it gets absorbed. It is quite helpful. And then also there are transdermal patches that are available. Now again, coming to non-pharmacological management. Yes. So what are the different non-pharmacological managements for a patient who is having severe vomiting or nausea? Like we said, environment, the environment also plays a major role in contributing to nausea and vomiting. So we need to make sure there is no bad odor. There's a lot of fresh air that is coming in to the patient's room. Also, if the patient is having a vestibular issue, give the patient a lot of bed rest, along with, of course, there should be drugs to control, and also good oropharyngeal hygiene, because again, there is always constant expulsion of the gastric contents, which itself could be a bit foul smelling. And sometimes what happens is that when there are things like situations like intestinal obstruction and the patient is having vomiting, there is also fecal vomiting that is seen. So these are all very distressing for the patient. Now, good oropharyngeal hygiene to minimize halitosis, prevent oral thrush, all these are important. Now, nursing in the upright position. Always have vomiting, they also have a risk for aspiration, isn't it? So especially frail, debilitated patients, patients who are bedridden, if they have severe vomiting, there is a higher risk for aspiration. So what happens if there is severe vomiting and you put a Ryle's tube? So do you think these patients are much safer? Patient is having severe vomiting and is on Ryle's tube. Is that just enough to settle the problem? Will that patient not have any more risk of developing vomiting? Maybe not. That's a very wise answer. Dr. Newsta? Yes, Dr. Shani, Dr. Anish, Dr. Nari, Dr. Mrinalini. No, that is not sufficient, is what they say. Okay. Yeah. So even if a Ryle's tube is put in, probably all the vomiters gets collected onto that bag. But what happens? What if the patient is having severe ascites? There is an increased abdominal pressure, and you're putting a Ryle's tube. If the cause is there precipitating, definitely the patient is going to have regurgitation. That itself can cause aspiration. So generally those patients who are having severe vomiting, it is better to keep them a bit upright, a bit of head elevation, maybe a 40 degrees at least. Now, again, avoid situations which induce nausea and vomiting, and also good, suitable distractions is good. So that is why in chemotherapy daycare wards, especially where patients just come, they take their chemotherapy and they leave. The daycares have, they have facilities in for like some TV or magazines where the patient can have distractions. And this can in turn help to reduce the nausea and vomiting. Okay, so that was non-pharmacological management. Now, again, one more word about distraction. There are also other more professional methods where they can have distraction, like self-hypnosis, progressive muscle relaxation, biofeedback. All this can be used more effectively for anticipatory vomiting. Okay, so if your patients are someone who is suffering from anticipatory vomiting more, you can direct them to the psychologist where they will give more of these techniques. They are more qualified for that. Okay, and these can be used along with antiemetics. Okay, and this combination together is going to make them feel more confident, and they feel that they're more in control of their vomiting. And also, what are you going to advise them? What are they going to eat? You will have to not just prescribing an antiemetic, but you will have to tell them how should they be eating and what should they be eating. All this is very important in your management of nausea and vomiting. So your role as a doctor does not finish when you have just identified the cause, you have prescribed the medications. It also goes along with giving advices on what more or how else can they manage the situation. Okay, so your nutrition advice on asking them to have small frequent feeds, okay, small frequent feeds, rather than having like a breakfast, lunch, dinner. They can split that and have it as small frequent meals, and also consuming most of the food in the daytime, because maybe having it more towards the latter part of the evening or at late bedtime might cause more of nausea issues or vomiting issues. Okay, and also to have food which is more easily digestible and not too spicy, not too sour, or not too sweet, or not very highly oily food. Okay, all these can cause more nausea. And do not force feed. So sometimes it happens, the family is so loving and supportive to the patient that seeing them just vomiting and vomiting, they feel that, oh, that their loved one has not eaten anything, and then they try to force feed them. So that also can worsen sometimes the nausea. And it is also found that cold food is better tolerated, and it is also advised to avoid fiber and carbonated drinks. Okay, and if the patient herself or himself is making the food, you can ask someone else to do it, because that probably is the trigger. And if there are a lot of dietary kind of specifications that is being advised for the patient, because the patient is a diabetic or a cardiac patient, all these can be relaxed at this time. Ask them to eat what they like instead, okay, for this short span of time, because trying to control the diet of a patient who is already having a severe nausea and vomiting might not be a good idea. Okay, and of course you can always direct the patient to also a dietitian, because the dietitian will also be able to give better tips on what to eat, and how much more they can make alterations in the diet. And also, what more, you have to keep the mouth clean. You have to tell them not to wear too tight clothes. And also to have a lot of fresh air coming in, that we did say in the non-pharmacological management. And also very loud sound or very strong smells, all these could also kind of stimulate or trigger the nausea. And if the patient is having continuous or refractory vomiting, always also remember to give them a contact number uh, through which they can contact you, so that you can advise them accordingly what to take next. All right. So now what you need to do is document what are the likely causes, and if there is any reversible causes in it, or anything which is an exacerbating factor here, address it. Okay, so it could be sometimes the drugs that the patient is taking, the patient is on NSAIDs, the patient is on oral chemotherapy. See if that can be just temporarily stopped until you can control the vomiting. If it is a refractory vomiting, you might have to stop it completely. Or if it is something you can control, you can relax it a bit, probably give the drug also along with it, and step up your antiemetics. Okay, it doesn't mean that in every situation that, say, suppose a patient is on chemotherapy, oral drugs, and the patient is having vomiting, it doesn't mean that you have to stop the drug completely. You try adding your antiemetics. Maybe it is one antiemetic, maybe it is two antiemetic combinations or three, and see if the patient is able to tolerate the chemotherapy. If still they are not able to tolerate, you might have to just completely stop the chemotherapy drug. Discuss it with the oncologist also. Okay, and again, if it is constipation, you need to look for reversing the cause. So you have to give laxatives, clear the constipation. If it is severe pain, like one of you was saying, it could be the pain that is triggering it. So control the pain. That itself probably will decrease the nausea, vomiting. If it is infection, if it is a urinary infection, treat the urinary infection. Okay, all these are reversible issues. So by treating that, you are also going to be treating the vomiting in a different way. And of course, you have to combine it with antiemetics, right? And also, whatever you do, review after 24 hours. And again, you might also have to review the cause if the nausea and vomiting is not settling. And like we just said before, there are patients who need more than one antiemetic. Okay. And if you have put the patient on parenteral antiemetic, you need to wait for almost 72 hours before you can change to an oral antiemetic, and then you can taper it off or stop it once it is totally in control. So these are your pharmacological management that you have to be giving to your patient. You have anticholinergics like hyoscine butyl bromide, like buscopan can be given, dicyclomine can also be given. And buscopan, hyoscine butyl bromide, is also an anti-secretory agent. It is very helpful in palliative care. We very commonly use it. But I do understand that many centers are having a problem. At least in Ernakulam district, many centers are having a problem procuring, getting hyoscine butyl bromide these days. I don't know how it is in other states. And okay, also we have D2 receptor blockers. We have prokinetic drugs like metoclopramide, domperidone. Now, about prokinetic drugs, what they do is that they try to stimulate the forward action of the gut, along with bringing down the emesis. So it is helpful in two ways. So if the patient is severely constipated, or if the patient is having hiccups and also vomiting, so this will help. Metoclopramide helps, or domperidone helps. It helps to in the forward propulsion of the peristaltic waves. So, and also it helps to decrease the vomiting also. Okay. So then also you have other drugs like aprepitant, which is a NK1 receptor blocker given for anticipatory vomiting. And then you have antihistamines, very commonly used injection oven. It is also given. And also you have 5-HT3 antagonists. It is widely being given these days: ondansetron, granisetron, palanositron, ramasitron. So many preparations are available. And then you have the adjuvant antiemetics. Okay, so you can give dexamethasone. Now, dexamethasone can be given at probably a 4 mg dose. That's usually, I mean, this is how we prescribe for severe vomiting or that patients have, and they in turn have anticipatory vomiting. So sometimes what we do is that we prescribe a dose to be taken the previous day of the scheduled chemotherapy. We ask them to take dexamethasone and come, because it has a very prolonged action. So just a one dose is needed, and it lasts till the next day the patient has come. Or sometimes even we try benzodiazepines, lorazepam. So all these can be tried for even refractory vomiting. You can give your patient dexamethasone. You can plan it as parenteral or oral according to how the patient is tolerating. Or if it is a refractory severe vomiting, definitely parenteral. And then you have benzodiazepine. Benzodiazepine, lorazepam, can be given even sublingually. Say about 2 milligram or 1 milligram can be given sublingually. And it can also be taken orally. Okay. And it can be given even, I sometimes give it for anticipatory vomiting as a HS dose at bedtime. Okay. And all these are also helpful in managing nausea and vomiting. And again, haloperidol, usually for opioid-induced vomiting, haloperidol or Serenase is usually given. And we started off at a dose of about 1.5 milligram. Or sometimes if it is severe vomiting, we might have to hike up the dose and such to about 5 milligram per day. Or sometimes even continuous subcutaneous infusions are required for terminal patients with severe vomiting, with gastric outlet obstructions or intestinal obstructions. We might have to give haloperidol. Okay, and again, metoclopramide. Metoclopramide again can be given for patients. It can be given 4th hourly. It can be given 6th hourly. It can you can change it according to the severity of the symptom of your patient, and it can be given orally, subcutaneous, IV. Now, the good thing about metoclopramide and domperidone, as we said, they are prokinetics. Okay, so it is helpful in that way. But again, what we need to keep in mind is that, say there is an obstruction. Say there is an obstruction, and you are giving metoclopramide, which is a prokinetic. What happens? What would happen? Yes? What do you think? There is an obstruction, it might increase the pain. Yeah. But Dr. Jennifer says it could lead to perforation. Dr. Newstar says it can increase the pain. Yes, it can increase the pain, right? Dr. Mohammed also agrees to it. It can cause severe pain. It's going to aggravate whatever pain was there. Why? Because there is an increase of the peristaltic waves and it's going to mount on top of the other. There is more of the waves which the colicky pain, sorry, there is more of colicky pain that is going to result because it is a prokinetic. Okay, so you need to think about which antiemetic you would like to give to your patients who is also having a severe abdominal colic along with vomiting. Okay, and in these cases, I always like to prefer for hyoscine butyl bromide because it is an antispasmodic and also an anti-secretory. So it helps to decrease the colicky pain, and also it is an anti-secretory, so it helps to bring down the volume of the vomiting. Okay. Now, ondansetron, again, it is a serotonin receptor blocker, antagonist, and you can give it 8 hourly, 4 to 8 milligram 8 hourly, and there are various preparations available. And again, commonly used, again, you have octreotide and dexamethasone also I would like to add in here. Here, octreotide is also another anti-secretory agent. Like I was telling you about hyoscine butyl bromide. Again, octreotide is also another anti-secretory agent, but definitely expensive, much more expensive than hyoscine butyl bromide. You can also give dexamethasone, like I was talking about before. It is not just used for situations where there is a raised intracranial pressure causing vomiting, but also other causes which can lead on to vomiting. Like how we were saying, in the previous slide, we were going through what are the different causes. Yeah, this one, where the ones in white, the pressure receptors, hepatomegaly, where there is a capsular stretch of the liver capsular stretch, or there is an intestinal obstruction. All these are situations also where the dexamethasone is going to help. Okay. Right. So diphenhydramine is also given as a pre-medication for before chemotherapy to reduce the nausea and vomiting, and also it helps to bring down the allergic reactions. Okay. So generally what is done is that a complete histamine receptors is blocked before the chemotherapy is given as a pre-medication. That is H1 receptor and the H2 receptor. You give injection Avil, and you give injection ranitidine, and both are blocked as a pre-medication. Yeah. So now we move on to the next topic. Yes, it's 6 o'clock. We have to move on to constipation. Yeah, so constipation, when do you say that the patient is constipated? Is it just that the patient does not pass stools? Is it just when the patient is not passing stools that we say it is constipation? No. Yes. Dr. Gregory says no. So what else is it? Passage of hard stools. Dr. Mrinalini says it is passage of hard stools. Yes. Dr. Shaleen says it's fewer than 3 movements a week, or it is decreased frequency. Dr. Mrinalini says, and Dr. Sanchia says it's a feeling of inadequate emptying. Yes. Yeah. So we understand that constipation is not just when someone comes and says, I have not passed stools. Is different, right? It's a difficult or painful defecation and is associated with infrequent bowel evacuations and hard feces. Okay, and it is a subjective feeling. It's a very subjective feeling, and what you need to ask is how different is it from your normal? Because for some people, even once in 3 days, passing bowels, passing motion is normal for them. Their normal is once in 3 days. So just because the patient has not passed, opened his bowels the previous day does not mean that that patient is constipated. You need to ask how different is it from your normal. Okay. So 45% of palliative care patients are constipated on admission. And we need to know that most of your patients in palliative care, when you go to, especially in home care, when you're seeing bedridden patients where mobility is less, intake is sometimes compromised, most of those patients are going to be constipated. So how do you manage constipation? Before coming on to that, this is what they would be telling you, that they have an incomplete feeling. One of you already said, some may say they are feeling very bloated, some may just present with nausea, vomiting. And then when you ask back, you might get the history that they have not passed motion for about few days. Then some of them might have severe abdominal cramp or bowel obstruction or overflow diarrhea or urinary infection. Now, these are two things that I would like to highlight on when it comes to the symptoms of constipation. What is overflow diarrhea? We are talking about constipation, but at the same time, now I'm saying that the patient can have diarrhea. What is overflow diarrhea? It is quite common in palliative care. The family might tell that the patient is going on passing loose, uncontrolled stools, bedridden patient. And you tend to give, maybe anti-motility drug or stool enhancer, bulk enhancer or something. But actually you are looking at constipation. Do you know why a patient with constipation presents with overflow diarrhea? Have you seen patients with constipation presenting with overflow diarrhea? Now, what happens is that when there is a hard fecal mass and the patient has not opened his bowel for many, many days, the fecal matter on the top, it starts to necrose and it starts to liquefy and it starts passing through the sides. This is overflow diarrhea. So when your patient is being told to have diarrhea, always ask, when was the last normal stool you had? When was the last time the patient opened the bowels? And maybe they will say, it's probably been a week. So then you know this is not a normal diarrhea, this is overflow diarrhea. You might have to do a per rectal examination. If you do a per rectal examination, you will feel hard impacted stools. Right? Now, urinary retention. When you go to homes for home care in palliative care, another also commonly seen thing is that patients have, the family tells you that he or she has not passed urine since last night. Or the patient is on catheter. Just last month, I went to this house where they gave an emergency call. The catheter is blocked. So this is happening frequently. And they are saying we have to change the catheter, we have to change the catheter. So we as a home care team, we went with the catheter, with a new catheter to change the catheter. But it was just recently changed a couple of days back. And again, that got blocked. So then I just tend to ask the patient caretaker, when did she pass stools? So she told me, yeah, she's been passing little stools. That is no problem. She doesn't have a problem at all. She's passing little stools. Now, before I could take her words for granted, I just had to think, okay, wait a minute. She's going on passing little stools. So there is something more to it. Before I could insert a new catheter for that patient, I told the staff, come on, let's do a PR first and find out. So we did a PR, we found hard impacted stools, we evacuated the fecal mass from there. And very shortly, the catheter was running fine. So it can lead to urinary retention in not just patients who are not catheterized, but also catheterized patients. Okay, that is what we need to know. So again, yes, we did get answers over here. I'm sorry, I didn't see that. Dr. Priyanka and Dr. Satya also had added to it is what was overflow diarrhea. Thank you for that. Yes. So now, how do we manage? What are the causes for constipation? So like we said, just in the case of nausea and vomiting, we also need to know what are the reversible causes here. Is it just the matter of giving laxatives? Are we able to control the constipation or relieve the constipation by just giving laxatives? No, we have to treat the cause even over here. So many causes are there. The drugs that the patient is having, the pain medications that you have given, that could be causing the constipation. There are so many drugs. Opioids are just one of them. Antidepressants, anticholinergics, anti-epileptics, antiemetics, antacids, somatostatin analogs. Now, all these being anti-secretory agents can also sometimes cause constipation. Okay. Now, metabolic causes like dehydration, hypercalcemia, hypokalemia, when there is the peristalsis itself is affected when there is hypokalemia, and then uremia, all these can cause constipation. Now, diet, if it is a very poor diet, low fiber diet, low fluid diet, all this can cause constipation. Environment, what if you are suddenly gone and put in a hospital general ward and you are asked to use the washroom which is being used by 10 other people? How comfortable are you? So all these can lead to also constipation. And what if if the patient is at home and the only person to take care of the patient is a little girl who cannot actually support the patient and make the patient sit on a commode? So definitely the patient is the elderly, say suppose the elderly lady is going to wait until evening till the adults come home so that she can pass motion. So inability to attend the call is also another issue. Neurological, paraplegic patients, they often need laxative help to open their bowels. Now, even if it is the disease per se causing the obstruction, it can be pelvic tumors, or because the radiation has caused some fibrosis to the area, and that itself can cause, or some fissures, some painful anorectal conditions. All these can cause constipation. So sometimes when there is constipation for a long time, the patient itself tries to put his finger, try evacuate the stool, or sometimes it is so hard and impacted, repeated attempts to pass stool itself will cause small little fissures in the anal area, which will cause severe pain. Now, the severe pain is going to further prevent the patient from putting full force. That itself will worsen the constipation. So you need to ask for so much details. So now you know that if the patient tells you, I have not passed stools, there are so many things that you need to have in your mind as a checklist. Because managing constipation is not giving laxative alone. It is to understand the cause and address the cause. Okay. And again, depression, weakness, immobility, inactivity, sedation, all these age, all these are also contributing factors. So you need to ask your patient, what is normal for you? What is usually your frequency, amount? How is the consistency? Is it blood stained or not? And when was the last bowel movement? Do you have any pain? Do you have any nausea, vomiting? Or are you feeling like, there is not proper emptying? The rectum is still feeling full. And are you using laxatives? Very, very, very important. When your patient comes to you, maybe in the OP, saying that I'm constipated. So then you'll say, okay, I'll give you laxatives. Patient will tell, oh, I have laxatives. I am taking laxatives. Instead of that, and despite laxatives also, it is not helping. Now, we get carried away hearing that, oh, it is not working despite laxatives. Then probably we need to look for other features, some intestinal obstruction, this, that. We need to find out which laxative are you taking? When all are you taking? How much are you taking? Now, it is so very common, when you ask them to take a little more of laxative, they are just against it. Because the last time they took a laxative is probably when they did not pass stools for a very long time. So say, suppose they have not passed stools for about 5 days and they came and saw a doctor. They have prescribed laxatives. And after taking the laxatives, what happens? The bowels get evacuated. And there is a whole purge that is happening for a day and the next day. Now, what the patients comprehend out of this is that it is a laxative which has caused continuous purging of stools. They do not realize that it is all that fecal matter which had got accumulated. And this they attribute to the laxatives. And whenever you ask them to have laxatives regularly for a normal, regular motion every day, they attribute it to that. And they say, oh, last time I had it, it was very bad. So I don't want to take laxative. So then you have to educate them. You must tell them, see, the reason you had such an issue is because you had not been taking it. And there was an accumulation of fecal matter. And that is why it was happening for 2 days, continuous. Also, you need to find out what are the medications the patient is on, or is there any medication which is causing constipation? So you need to do something about that. If it has to be stopped, it has to be stopped. Or if you can do something else, like add more laxatives, keeping that medicine going on, you have to suggest that. And if the constipation is a recent change, then you have to think about other reasons. Is there a new kind of pathology that is happening there? And what type of diet is the patient on? Suddenly the patient starts eating a lot of high fiber diet. That is probably a constituting factor. And now you have families telling that he has not eaten enough. How will he pass motion? You have to tell them, sorry, even if the patient has not eaten, there is a lot of shedding that is happening of the mucosal membrane. And, all this can contribute to fecal mass. So it doesn't mean that the patient is not eating properly means the patient does not have to pass stools. Okay. And also when a patient comes to you with diarrhea, always think of overflow diarrhea. Again, management comes to correct the correctable. Judicious use of laxatives, improving the general condition of the patient, symptom control, encourage activity of the patient, and immobility also contributes to constipation and increasing the fiber in the diet. But sometimes, if it is an obstruction, fiber can worsen the constipation. Okay. So the non-pharmacological management, always when we talk about management of a particular symptom, first think about what are the correctable causes, think about the non-pharmacological management and the pharmacological management. Okay, that is the order. So non-pharmacological management, how close is the washroom? The ability to go to the toilet, the access to the toilet, timing, privacy. Squatting position helps to make a defecation better. Encourage normal balanced diet and plenty of water. Yes, so if you have a patient constipated, do a rectal examination. If you find hard fecal matter, evacuation has to be done, and give the right laxatives. Suppositories can be given, but it should be placed properly. When you place a suppository, or the family is placing the suppository, tell them that it should be in close contact with the mucosal membrane, the rectal mucosal membrane, because sometimes they just push the suppository and it goes bang into the fecal matter, right into the middle of the fecal matter. It doesn't touch the mucosal membrane. So then it is not going to have any action. Enema, you can go for enema, phosphate enema, warm saline or plain water enema, glycerin enema, and generally try not to give soap water enema. Then again, digital evacuation for fecal impaction is very important. Now, laxatives, you can go for bulk forming laxatives. That is, it helps to increase the bulk of the fecal matter and cause propulsion of the fecal matter, and thus produce bowel opening. Or else you can go for lubricating types or osmotic, where it helps to absorb the water from the membranes and increase or make the stool more soft. That is through lactulose and magnesium hydroxide, or PEG that is given. Then stimulant laxatives, very, very commonly used in the palliative care, especially it is given along with opioids, bisacodyl. And again, stool softeners like docusate sodium are also very good, but not always available easily everywhere. Few recommendations: paraplegic patients need regular stimulants, stool softeners, and they may need manual evacuation. And even those patients with colostomies, they can have constipation. Even those patients with colostomies can have constipation. You might have to do an evacuation from the colostomy also sometimes. You can place suppositories also in the colostomy. Okay. Yes, so soft stools, you can give bisacodyl suppository. If it is hard stools, you can give glycerin suppository. If it is an empty rectum that you get, if you get a ballooned empty rectum on doing a PR, it means that the obstruction, the fecal matter is high up there. So then to give enema, you have to attach the enema to a probably suction tube, and you can push it up and give a high-end enema, and then give the enema, so that you get across the fecal mass on the top. Okay, so that is called a high-end enema. And oral stimulants also can be given. So again, manual evacuation, very important. It is a very distressing feeling for the patient when you're doing a manual evacuation. It intrudes into the privacy also of the patient. It is painful also because there is a hard mass pressing on there. So explain what you're going to do. Make sure there is privacy. Give a lot of lubrication with anesthetic jelly, local anesthetic jelly, and do it very slowly. Make sure that the patient is comfortable. Now coming on to the case. Yes, so this is a 54-year-old lady, and the patient is having CA stomach, now having UTI, having vomiting, abdominal colic fever, is on antibiotics, and is having incomplete bowel movements, and is started on laxatives, and she is accompanied by her young daughter. So what are the issues here? Yes, now we can go back to this case. What would you suggest? What are the issues here? Okay, Dr. Charlene was asking what are the concerns of soap and water. So here the thing is that sometimes it can, recently they have said that, soap and water might not be sufficient because, not be properly done at home by the family. So that is the only thing that is being told about that. They might not be using it well enough. So that's all. Then Gregory, Dr. Gregory says, yes, UTI is the issue over here. So, and it's also a partial obstruction. Okay, because yes, there is infection, vomiting, and constipation. That is the main issues over here. Okay, right. So what could have led on to the constipation here? Well, the CA stomach need not necessarily cause a intestinal obstruction, right? Need not necessarily. So it's probably a constipation. Yes, environment, wonderful. Dr. Jason has said as a younger daughter, Dr. Shalini also agrees, as a younger daughter, that's it could be an environmental issue for constipation. Another more important reason that could be contributing to the constipation. Yes, Dr. Neelam says probably chemo-induced also, definitely. That could also lead to vomiting, that could also lead to constipation. What else could have led to constipation here? The patient is vomiting a lot, right? There's a lot of dehydration happening. So that also could have led to constipation. Okay. And yes, as she is a frail lady, Dr. Jyoti says, as she is a frail lady, she might not be able to go to evacuate alone. And the young daughter might not be able to have exactly, yeah. A lot of you have been saying about that. I'm so happy that you all have brought it up there. So how would you like to investigate? Yes. Someone who has developed severe vomiting and then constipation, what would you like to investigate? Yes, Dr. Gregory also says poor food intake could have led to constipation. Yes. Yes, Dr. Jason says electrolytes. And Dr. Mrinalini also says hemogram and biochem profile. Dr. Arnab says hypokalemia. Yes, Dr. Neelam also says about electrolytes and dehydration. Yes, that's wonderful. Yeah, electrolytes would be something that we would definitely want to see. And Dr. Aisha also adds on urea. Yeah, and yes, so definitely hypokalemia also could have contributed. There's so much of vomiting happening, so much of electrolytes that is getting impaired in the process. That all could have led to. And abdominal erect X-ray, probably if we are suspecting an intestinal obstruction, we could think of it. And APG, I'm not sure why we would like to understand until, it's an indirect way that we could also look at the electrolytes. Yeah. Urine analysis, yes, we already know that the patient is having UTI. Dr. Rajni says a rectal examination. Thank you so much. That's wonderful. Yes, the patient definitely needs a rectal examination and whether evacuation needs to be done. Disseminated cancer in the peritoneum can cause vomiting and colic and should be in the horizon. Definitely. Thank you, Dr. Shilini. That is a very important info also. And yes, Dr. Anish was saying venous blood gas, lactate ketones to rule out starvation ketosis. Oh, okay. That is why you wanted to do. All right. Thank you. So all these are possibly the investigation that could help us get on track, right? And how will you manage? How will you manage this patient? You do a rectal examination, okay, and if evacuation has to be done, that can be done. So this patient has started on laxatives today. So maybe you can give it a wait, or would you like to immediately relieve? Would you like to wait giving those laxatives? Patient is having severe vomiting. So probably the constipation, the increased abdominal pressure is also contributing to the vomiting, right? So we would also like to give an enema here, okay? Because we want to relieve the constipation fast enough so that it can also help to bring down the vomiting, okay? Yes, I am rushing it now because I know I am running late. Yes, so this is the X-ray that was taken for the patient, and you can see the fecal mass there. Yes, Dr. Mrinalini wanted an X-ray, right? Yeah, so this is the erect X-ray that was taken. So we do not see multiple air fluid levels here. So possibly, so it is not a intestinal obstruction. It's just a constipation we are looking at, right? So you would like to do a enema and also give laxatives. Put the patient on regular laxatives so that this does not occur again. Yes, so this is just another scenario. Mr. Roy is quadriplegic who is given fees through nasogastric tube, and he is presented with vomiting since 2 days and appears sick. You have visited him at home. So what is the reason that he is developed vomiting through his Riles tube? I mean, he's got a Riles tube, but despite that, he's vomiting. What could be the reason? Yes, I had a question here. Dr. Arnab is asking, is that a suppository? Were you asking about how would you like to manage? Is that a suppository? Would you like to give a suppository? Oh, okay. Yeah, you could try a suppository, or you can try a enema also. Yes, yes. So this is our question. What is wrong with Mr. Roy? Why is he vomiting? Yes, check the Riles tube position. Yes, Dr. Ani says check the Riles tube position. Dr. Arnab says take an X-ray and see if the Riles tube is in position. Sometimes you are visiting these patients at home, and we might not have access for, they are bedridden, and you might not have access for X-ray. So what you can do is that give a push, and also you can check if it is in position by auscultating at the epigastric. And again, very rightly said, Dr. Gregory, overfeeding by the relatives or the caretaker can also be another issue. So you need to very rightly ask them. You should be asking them, when all do you feed? How much do you feed? All that. And Dr. Neelam, yes, says that aspirating the contents. Okay, that is also a very common complication that happens. So always remember, like we said before, keep the head end elevated. Dr. Rajni says decreased activity and constipation is also a problem, which could have led to this. Yes, very right. The increased abdominal pressure could also probably contribute to it. And Manjari, Dr. Manjari says infection, local or general, has to be also done since he looks sick. Yes, it could have probably led to aspiration or pneumonia, and the patient is sick because of that. And Dr. Jyoti also says he could be fed by RT in a slight upright position. Yes, so that's all wonderful answers. Thank you so much for those answers. Very rightly said. So that's all for now. So when you have a patient with nausea, vomiting, and constipation, evaluate, manage, monitor, assure the patient. And this is how you go about management. Correct the correctable, non-pharmacological management, pharmacological management, and then your interventions. And always address the physical, psychological, spiritual, and functional concerns of your patient, because this is palliative care, and we look just not at the symptom, but at the individual. Yes, this is my reference. It's a beautiful book, the Oxford Textbook of Palliative Medicine. If you get a chance to read it. And thank you. So we should move on to the presentation today. Dr. Mrinalini is presenting.
Yeah.
I'm so sorry. This is taking time.
No need to apologize, because these are very important topics and needs discussion and feedback from the participants. So thank you for spending that time with us. We will quickly go to the case presentation, and then we'll come back to the discussion. Yes, Dr. Mrinalini.
Hello, good evening.
Yes. Yeah, you are right.
Well, most of the concerns in my case presentation have already been discussed. But let us start. My patient is a 70 years old female with a diagnosis of carcinoma cervix, stage 3B, and histology was a poorly differentiated squamous cell carcinoma. The presenting complaints were patient presented to the OPD with complaint of discharge per vaginum and postmenopausal bleeding per vaginum for 4 months. There was history of weight loss about 5 kg in 4 months. And then we evaluated the patient, and patient diagnosis of CA cervix was made. And then patient was started on chemoradiation therapy. She was planned on 46 gray in 23 fractions. And after completing 10 fractions of the chemoradiation therapy, she was having complaints of nausea, vomiting, and constipation. History of illness. There is history of discharge per vaginum started 4 months back, which was foul smelling, occasionally blood tinged. There is history of postmenopausal bleeding per vaginum started about 3 months back. There is history of passage of clots along with it, with soakage of about 1 to 2 pads per day. For these complaints, she visited the gynae OPD and examination and biopsy was done, suggestive of carcinoma cervix stage 3B, squamous cell histology. Patient was started on chemoradiation therapy, planned for 46 grain, 23 fractions to pelvis with weekly injection cisplatin 50 mg IV. In the second week after completion of about 10 fractions, she started having nausea and vomiting. There were about 7 to 8 episodes of vomiting per day, which were mainly following meals. She had decreased intake due to persistent nausea and vomiting. She then developed constipation and was unable to pass stools along with colicky pain abdomen. On examination, just a general examination, her general condition was fair. She was dehydrated. Konosky performance scale was 70. On per abdomen was distended. Bowel sounds were normal. Treatment and significant investigations. A complete hemogram and biochemistry was done. Plain X-ray abdomen was done to rule out intestinal obstruction, which came out to be normal. It was radiation and chemotherapy induced nausea and vomiting. She was then she was given adequate hydration and antiemetics and PPI. Oral lactic acid bacillus preparation was given. Her chemoradiation treatment was withheld. She was given a per-rectal enema for constipation. And these symptoms continued for 2-3 days and then gradually relieved. Psychosocial aspect. She is a 70-year-old female having a diagnosis of carcinoma cervix. It is very uneasy for women in this age group to undergo vaginal examination, and hence they hide their symptoms and only visit OPD when the disease has progressed. She had family members support all the time, but nausea and vomiting made her feel sad. She was not able to eat anything, and whatever she ate, she vomited out. Due to decreased intake, she had constipation. There was colicky pain abdomen, and repeated attempts to pass stool with straining made her abdominal pain worse. The treatment needed to be stopped for a few days, and she was worried that due to this, her son and daughter-in-law have to extend their leave for taking her care. The caregivers were worried that treatment is causing her more harm than the disease itself. Medications. Her complete hemogram, biochemistry profile, electrolyte, every investigation was normal. So I just used the symptomatic approach and I gave her IV fluids, antiemetics, which were ondansetron and PPI, pantoprazole was given, oral lactic acid bacillus preparation was given, and a per rectal enema was given. Main concern, she is a 70-year-old female with carcinoma cervix with radiation and chemotherapy-induced nausea, vomiting, and constipation. She is having depressed mood due to disease and unable to take meals, worried about her caregivers, and caregivers are worried that treatment is causing her more harm than the disease itself. So to summarize, she is a 70-year-old female with carcinoma cervix stage 3B on chemoradiation therapy with radiation and chemotherapy induced nausea, vomiting, and constipation with low mood and anxiety. How can the patient be counseled about the situation? What other interventions can be made to resolve the condition early? And how can caregivers be counseled in this situation regarding completing treatment? Thank you.
Thank you, Dr. Mrinalini, for the very detailed presentation. Some of the questions on most of the questions on nausea and vomiting, I guess, been answered. As we are running out of time, I'm directly going to Dr. Vineetha, and others can keep typing in the chat. What do they think about how to talk to this patient as well as to the caregivers about this particular situation?
Thank you, Dr. Mrinalini. It was a very nice presentation. And as you can see here, the patient over here is having CA cervix of stage 3B, 70-year-old, and she's having to undergo brachytherapy. And counseling about expected side effects, steroids can help in CA. Yes, definitely. So our first question here is, how can the patient be counseled about the situation? So I think we have to start right from what the patient understands about the disease, about the treatment, how it is actually going to help her, or is it just to buy time? So all that is also going to add on her confidence psychologically, which will help her to understand that is a temporary period. Yeah, so which is going to help her understand that it's a temporary period that she has to just forego during this treatment period, and then she is bound to get much better after that. So I think patient wise, we have to make her understand about the importance of taking laxatives and antiemetics, and how she can manage her diet during this process. All that has to be done. And again, we have more inputs coming here, relieving the constipation and vomiting. Yes, that's definitely there, because we just understood that vomiting and constipation, I mean, nausea and vomiting is not just one single symptom. It is caused by so many other factors. So especially if there is a constipation, that also has to be relieved. And again, so much of vomiting is in turn causing dehydration, which is worsening the constipation. So both these things have to be looked together. And now, being a patient who is undergoing brachytherapy, I think very another important thing that we have to keep in mind is that RT-induced diarrhea itself can happen. So when you are prophylactically prescribing your patients with laxatives, thinking that, oh, this patient is taking chemotherapy and radiation, so this patient is going to have constipation, so it is good that we shall give prophylactically a laxative. You might just have to watch out for these patients in particular, because RT itself can cause diarrhea in some patients. So you have to judiciously use laxatives in these patients prophylactically. Okay. And yes, we have other inputs here, like laxatives given along with opioids. Do we need to give any antiemetics throughout the course of chemo and RT? Yes, definitely we have to give during chemo and RT, especially in this case, because it is a cisplatin-based therapy that the patient is taking. So cisplatin is one of those platinum drug platinum-based chemotherapies, which is severely having a severe emetic potential. Also, Dr. Priyanka says relieving constipation, vomiting, definitely. And also, Dr. Manjari says would help in patient and family is consult before chemo and radiation with common side effects and what can be done if it occurs, and the risk-benefit ratio. Communication at every step will help compliance. Definitely, these are so important. Communication is so important.
Ma'am,
Yes.
can anything be done to resolve the condition early? Because ma'am, it gets really difficult sometimes for the patient, to convince a 70-year-old female having
Yes.
so severe nausea and vomiting to complete her treatment.
Yeah.
So can anything be done despite giving these antiemetics and PPIs? We can do anything early can be done for this thing.
Yeah, we can start the patient prophylactically also on antiemetics, and also, like I said, judiciously use your laxatives, because we do not know which category the patient is going to fall under. Is the patient going to have a brachy-induced diarrhea, RT-induced diarrhea, or is it that the patient is going to have a cisplatin-induced constipation? So you will have to just it's a tricky situation. Since you're going to be seeing the patient often, and also give your contact so that they can contact you as and when they are having an issue, that can also be done. And also giving laxatives, antiemetics will help to resolve the issue. Then other causes like halitosis, oral thrush, making sure all those are addressed early enough. And if the patient has mucositis because of the chemotherapy, treating that early enough. All these things will also help to, you're intervening them early enough so that it could probably lead on to a severe vomiting. So you can cut that in between or early enough.
Dr. Newstar has a question on subcutaneous infusions. Can it be given at home?
Yes.
And how do we give and commonly used drugs?
Yes. Yes. Thank you, Dr. Yusta, for that question. I'm sure a lot of you also had this query, so it just helps to it helps others as well. So yes, we can give continuous subcutaneous infusions from home. You might need health personnel to come and fix it at home. Probably the palliative care nurse will be able to come and fix it at home. And this can be monitored by the family. And sometimes boluses also can be given as and when required. And these are very helpful in case of terminal patients for good symptom control. And yes, we can also give it with syringe pumps, infusion pumps. And pretty much most of the drugs that we use commonly in palliative care can be given through subcutaneous continuous infusions. And NSAIDs we do not give, definitely. And what about the dosage? Okay. Dr. Sridevi, do we have time to
Yeah,
actually
we
discuss
don't
that?
have
I'm
any
not sure.
we don't have any other session specifically for subcutaneous infusions, so we can just touch upon that quickly. Yeah.
Yeah, there are probably we can give some handout on what are the
Yes,
dosage
definitely.
of
I
the.
have a few articles on
Yeah.
subcutaneous
So
infusions, so
I
I
think
can
that
do
we can
that.
share it with you.
But a quick answer, most of the medications in palliative care can be used except the powdered ones or the thick oily ones, but whatever we have mentioned. I'm sure Dr. Sunil has mentioned the morphine doses subcutaneous during his session on opioids, how to convert from oral to subcut and IV. Those conversions were mentioned. So morphine, yes, we have covered in that. And I think in Dr. Vineetha's presentation today, she was mentioning about the metoclopramide continuous infusion, and all those can be, suppose you are giving 30 milligram or 24 hours, you can give it subcut or IV, both ways. So I'll send a few articles on subcut infusions. I'll do that.
Basically, you will need to know how much you have to give the patient over 24 hours and then load it and accordingly. Okay. And
Or if it is useful, sorry,
no,
or
no,
if it
no.
is useful, we do teach those sessions for nurses. So I can send a recorded lecture of those sessions. Shripriya, we have that, right? Subcutaneous infusions for nurses course. So we
Yes,
can
ma'am.
send that particular session to you all. So that will be like elaborate how to give and the procedure, everything is mentioned in that video. So we'll share that link. We'll put that in the resources, Shripriya, just one extra link.
Sure, ma'am. We'll do it with the resource of this session. We'll do it.
Yeah. So are we done with all the discussion points? Have we left out anything?
Dr. Mrinalini, if there are any other questions from your side, unanswered.
That's okay, ma'am.
How can caregivers be counseled is the last one there.
Yes, ma'am.
Yeah, I think. Yeah, does anybody want to contribute to that? How can caregivers be counseled? I think it is also important for the caregivers to know what is the treatment and what is the outcome of the treatment going to be. How is the prognosis of a carcinoma cervix 3B going to be, and what exactly is in plan for this patient. So if the family doesn't know that, they have to probably meet the oncologist and get an idea about that, or we can give information on what can be the outcome of this, so that they don't see whatever is happening as something that is not being which is not justifiable for that patient, but it is just a temporary phase which the patient has to undergo. Now all this also depends on what was the performance status of the patient in the beginning, how what was the quality of life. So whether actually if the patient was not much of an active patient at the age of 70, was it actually justifiable treating her with an intensive treatment like this? at the age of 70. So it also depends on that. So it is only according to that, actually, the patient is able to accept and the family is also able to accept. If she was a lady who was hale and hearty at 70 years and, going around doing all things at her home, and then she had to go through this, probably it's just a matter of time she gets better after the treatment and she's able to come back to her routine. So that has to be also counseled. And how to treat each, how to support the patient with these symptoms of nausea and vomiting and constipation. What are the diet modifications that can be done? What is the environmental modifications that can be done? Non-pharmacological managements that can be done. All that can be counseled.
Yes.
I think we can wind up today's session if there are no other questions. But the discussions were, the interactions were really good, and the discussions were really fruitful. And thank you so much, Dr. Vineetha, for once again taking the session. And we'll be seeing her again for another topic under GI symptoms soon. Thank you so much for being with us. Thank you so much, everyone, for being so interactive during the session.
Thank you so much, everybody. You all were so interactive that, I didn't even know the time go by. Honestly, that's the reason that we crossed the time. I was just enjoying it. And thank you so much, Pali. Thank you, Sridevi. Thank you, Sripriya.
Thank you, Dr. Vineetha, for joining us towards the end of the day. We do know that how tired a person like you would be after a busy schedule, and still you found out it is going to be almost 2 hours. Actually, you were the first one to join the session today at 4:30. So it is more than 2 hours to be precise. Thank you so much for your time. And yes, of course, we'll be seeing you again day after tomorrow for another interactive session like this. And thank you, everyone. And before signing off, just a reminder that we will be having our session on palliative care in non-cancer illness tomorrow at 5 p.m. So please do log in. Please do arrange your schedules accordingly. So with that note, this is Sripriya along with Dr. Vineetha and Dr. Sridevi signing off from the Tips Echo Hub. See you tomorrow again. Take care. Bye-bye.